It might be like, oh, the wet is overflowing. I mean, the water's overflowing. The moist is overflowing. Or the moist is too much.
They get close.
Yeah, like they understand what's happening, but they're not like assigning the right words to the ideas that they're trying to convey.
Close, but no cigarette.
Yeah. Excellent. Wow.
How to be patient.
So welcome back to How to Be Patient, the podcast where we talk about patience and do a lot of talking, which is germane to our subject today, which is aphasias. Margaret, aren't you excited to talk about aphasias? Margaret's not excited to talk about aphasia.
I didn't say that. I'm excited to learn from you. Listeners, we have waded into the area that is far from my brain at this point, 3 years far of neurology. And
we're going to wade into many different areas of your brain, actually.
I was just practicing.
Lobes.
I was just thinking all the ways, like some way I could make some pun around. Preston, you always make me speechless.
I do. Yeah, I take the words right out of your mouth.
I'm going to be nice to you the entire episode and see if you can keep up the usual banter with it.
So, listeners, before we could start this episode, Margaret couldn't get her microphone to work, which was extremely relevant. And so it was basically just a one-way conversation with us. So in a way, Margaret was getting us started on like one of the first aphasias that we'll talk about, which is Broca's aphasia, or the inability to produce motor speech.
You heard it here first. Preston wouldn't let a woman talk.
I think you just loved the content so much you wanted to cosplay it.
Yeah, that I was trying to really get into understanding and build my empathy.
Before we get into that, I was like, this is a Preston guided episode, so that everyone knows. And I was like, are we still doing icebreakers? Like, how do we want to weigh that out? And then I decided I still wanted to do one. And it's because when I was first introduced to like aphasias and these kind of areas, I was in Psych 101 in like high school. So my question to you, Margaret, is what was your first psychology class like? And where were you?
I don't think I took psychology till college, and it was my freshman year at Notre Dame. And it was like
freshman psych 100.
It was, right? Yeah, it was a 101 class. And I remember that the guy who taught it, I can't remember the professor's name. At this point, it was like a 100-person class. Like, I just remember at the end of our, like, the first lecture and the last lecture, he was like, some of you guys are already drinking at the way that alcoholics do it. And it's not just going to stop once you like leave college. Like, you are building your character now. Please stop drinking, as if like, well, you'll just stop and become like a different sort of like person. And he like went on a rant, and he had really long gray hair and was like, would cuss and stuff during class. He was great. He was very eclectic. So that's my first psychology lecture course. What about you?
Oh, mine was in high school, and I just remember my teacher, I think a lot of psychology teachers are either eclectic or eccentric people, and she insisted on making all these puns that were like based in characters to help us remember the different parts of the brain. And so she'd be up on the board and be like, see this part right here? This is the cerebellum. Whenever you see this, I want you to picture a ballerina named Sarah. Well, her full name is Cerebellum, but she's really bad at being a ballerina. And then she would like dance around the classroom and like fall over and be like, see how bad her balance is? That's cerebellum. That's
actually kind of awesome.
Ballerina. And like, I say this as a joke, but here I am, like 2 years into psychiatry residency, probably going to apply to neuropsych fellowship. And I'm like, yeah, cerebellum.
You're like, I'm actually locked in on that.
Yeah.
Well, I feel like this is why I wish I'd had a teacher like that at some point for neuroanatomy, even at the simplest level. Because I feel like one of the things that confuses me so much with like functional imaging and some of the neuro stuff is that like it feels like it's in one ear and out the other in terms of like when people are like, this is what this part of the brain does, but not really, because now we're moving to brain circuitry, and I just like get confused.
Yeah, exactly. And that's actually what we're trying to do today, is make it like a little bit less confusing. And it sucks because like I feel like I have like a weak grasp on it, but I'm still holding on to it. And I started to confuse myself a little bit as I was researching for this video. And I was like, oh no, this is going to be like a blind lead the blind kind of situation. But
there was a comment on one of our YouTube comments recently that was like, I love this podcast. Are they always right? No. But they try really hard and they know they're not always right.
Are they always right? No.
They're like, keep it up, guys. And commenter, I love that. And that's honest. And we try to be right more often than we're not. But
Yeah, I don't know what our batting average is, but we're trying to get above
we're trying
50%.
to not be wrong.
Yeah. Or at least we're not like blatantly standing on misinformation.
Just apology
like,
now. Video.
Yeah, harm mongering or whatever else we're doing. So, like if we are wrong, it doesn't lead you to go, overthrow the Capitol or something.
We'll do an apology video at the end of every season from now on. Last time we had to do it with the eagle sound. This time, who knows?
Yeah, very true. So, we'll take a quick break, but when we come back, we're going to go over some of the models that we use to understand processing language and speech, the whole concept of aphasia disorders, and how we kind of think about that in the models we use to describe brain function. And we're also going to dive a little bit into the history of the story of how those things came about. To the best of Preston's ability, and we might get some stuff wrong, but we're trying. I swear,
New
we're trying.
listeners they're like, these people don't know. We do know things. All right, we'll be right back.
So one podcast that I think all medical providers should be aware of is the Sepsis Spectrum by Sepsis Alliance. It's run by this great critical care provider, Nicole Kupchik. One thing Nicole does really well is she captures the human story within infection. Anytime a person's involved, there's going to be a story involved, and she finds a way to bring sepsis outside of the hospital. And she helps experts tell the stories of patients who have sepsis in the community and teaches you how to recognize signs when there's problems to bring them into the hospital. We know that 87% of sepsis starts in the community, so it's important to make the conversations there.
If we know anything, it's that as many reps as possible, hearing as many iterations of presentations is how we recognize it better and more quickly. And this podcast can help all of us with that. And you can listen to the Sepsis Spectrum wherever you get your podcast or watch it on Sepsis Alliance's YouTube channel. To learn how you can earn free nursing CE credits just by listening, visit sepsispodcast.org.
Before we get started, Margaret, I want you to reflect on this statement. The brain is modular. What does that mean to you when I say that?
I'm reaping what I sowed right now in the psychodynamic episode. I would say that I would interpret it as this idea of the brain having like separate parts that do separate things rather than like a circuitry model where like different circuits go through different parts. So like that maybe the idea that used to be like, this is where this happens in your brain. Like this one particular area is what makes you be able to talk.
Yeah, exactly.
Is it right?
So, no, you nailed it. So it's just, that's how I think about it. Like I think of modules like little Legos, so it's like your brain is made up of all these different modules, and each module is responsible for a certain function. This module in this part of your brain is speaking. This part is understanding. This part is emotions. Like that's kind of how we have ascribed these modules. So you even got at this earlier, which is that this model of the brain being modular is imperfect and doesn't capture how our brain functions. But it's also not helpful, if that makes sense. And there are times where, well, okay, you would say it's not modular, and yes, but then when you knock out this specific part of the brain, it eliminates a very specific function.
Mm-hmm.
And that's kind of how we actually have discovered how the brain works over the last like several hundred years, is like one lesion at a time. We've learned like what's important. And it's harder for us to look at these more complex models because we can't just take it out one sliver at a time.
Mm-hmm. So when you say like it's helpful, it's like there are parts that maybe definitely are indicated in certain functions, but maybe it's not a complete picture to say like just that little one spot is the thing that caused it.
Yeah, exactly. So I guess the way I would think about it is like an engine where you have all of these different parts that work semi-independently, but they also are dependent on working together. So you have this like belt chain and as a part of your car engine, and you remove one part of it, it affects how they all interact with each other. But then
Mhm.
sometimes it can still continue to function, but sometimes you remove that linchpin piece and the
Right.
whole thing falls apart.
Gotcha.
So that's kind of how it's like modular and not modular at the same
Mhm.
time. However, it can be really helpful when you're trying to create models to think about it in this modular way. So a lot of what we're talking about today is actually it's coming from this paper called Aphasia and the Diagram Makers Revisited. It's by Kenneth Heilman in like early 2006. One of my attendings, shout out to Dr. Parker, she's a behavioral neurologist. She suggested I read this as a part of my training. This is kind of like the story of how we developed these language processing models today.
So you're saying story time.
Yeah, it really is story time. So we're going to be kind of following along in the footsteps of of our forefathers who came up with the ideas of where language came from. And no better place to start than with Paul Broca. What does that name mean to you?
Broca's region of the brain.
Hell yeah.
Something I can't. That's all I got. If you ask me any more of exact function, I'm gonna be like, let me pull up my flashcard.
No, yeah,
From now,
exactly.
you know, psych.
So he's the great his eponymous region is still known today, and he did a lot of great to contribute to neuroscience, and then he did a lot of not great in other regions,
Oh
just like every
no,
other person. So,
I don't know any of this.
yeah,
Okay.
we'll get into that in a minute, but I'm going to take us back to 1870s in France. So that's where Paul Broca was studying. He was becoming interested in neuropathology, and there was this lecture that he attended by this person, Auberton, and he was a student of Gall, who's kind of one of the first people to propose this idea of a topographical map of the brain, kind of implying that each region of your brain is responsible for a certain function, that kind of modular model we were talking about earlier.
Is that like phrenology?
Yeah, the problem with this is they extrapolated phrenology from that. So it
Yep.
was like, okay, a certain region of your brain is responsible for something, but then I should be able to palpate part of your skull, and then that tells me how developed or underdeveloped that region of your brain is, which lets me make inferences about your intelligence and reinforces the idea that like white people are
Yeah, we're back
superior.
at eugenics.
Yeah.
Yeah, you can't throw a stone too far in medicine before 1950 and not hit eugenics.
Yeah, you're just like, oh shit. So while like we know phrenology kind of was largely disproven as pseudoscience, the whole kind of concept of a topographical map was still like persisting at this time. And this guy, Auberton, was stuck on the idea that speech was totally confined in the frontal lobes. He was like, all speech comes from the frontal lobes. And he was like, I challenge anyone to find a patient who has like a speech production difficulty, and in their like autopsy, you don't see a lesion in the frontal lobe, basically.
Hmm.
And so Paul Broca is one of the guys in this audience. He's like, oh, it's pretty interesting. And sure enough, he he goes to the hospital to visit a patient with one of his colleagues, Laborg, and the patient has speech production difficulty. And so like, oh, well, very interesting. And it's, of course, the 1870s, and he was admitted to the hospital for cellulitis, unrelated to his
died.
speech production difficulty. Yeah, he died like 5 days later.
So they killed him.
Yeah.
Yeah, he died.
They were like, what are the chances? Like, I just saw this lecture on like speech production, and this dude I run into has issues producing
Mysteriously
speech,
dies.
dies. Yeah. And then sure enough, on the left frontal lobe, which is Broca's area, he had this this deficit. So then Paul Broca started doing a lot of work. He was like enthralled by this. So he starts kind of proposing that there are certain regions of the brain that affect your ability to produce speech. And he kind of basically took the idea that was in the frontal lobes and started to focalize it a little bit more.
When he was thinking of it, what did he mean by produce speech? Like, was there any division at that time of like, or was it just like, this is brain go talk, and this is the part that makes talk?
Yeah, that was the whole scheme at the time, was like frontal lobe equals talkie. That's how we do it.
Great.
And so that's kind of like where we are in the science now, until we have our new friend, Carl Wernicke.
Love that
So
guy.
he's not in France, he's over in Germany. And he's studying under Meinart, which probably sounds really familiar. So like the basal nucleus of Meinart.
Yep. I was like,
So
that sounds like something I had to memorize at some
yeah,
point.
Meinart had a lot of stuff named after him. He was also a neuropathologist. And he actually had this idea that psychiatric disorders can be influenced by disturbances in the brain in childhood, and that like issues with the brain could lead to mood issues later, which is like a revolutionary concept at the time when they're like, wait, psych disorders are just moral failures. Like these, this is an issue with the soul. What do you mean? Like if I mess up the brain, it could lead to psychosis. And
So
he's
at
like,
that time
no, I
we got
swear,
this
I think
guy
so.
saying that. We got Freud being like, maybe this is a lot of abuse is happening and impacting people. Everyone's like, no. Women are
Meinert's
lying.
like, maybe the brain is related to the mind, and everyone's like, shut up. But Meinert did come up with some cool stuff. He was able to figure out that we have a motor cortex and a sensory cortex. Like the anterior portion is like more of the motor cortex, and the posterior portion is for more like sensory input. So like afferent and efferent inputs. But he didn't localize anything with language. Wernicke, however, was able to find these patients that didn't have any problems producing speech. They could fluently construct language, but it was just nonsensical. And interestingly, they weren't able to understand speech at all. And these were different than Broca's patients, which they couldn't produce speech, but they seemed to have some intact understanding of speech when people talked to them and were frustrated by their inability to produce speech.
Is that different than to just compare like that versus like confabulation?
Yeah, so they actually thought that at some point a lot of these patients were confabulating or like psychotic or saying delusional, nonsensical things. But what happens is that these patients were like unable to communicate in like any sort of like grammatical syntax or coherency. So it's not that they were just like making things up. It was almost like they forgot what sounds go with what words. And so they created a lot of new words when they were talking. They're called neologisms, and they would just speak uninterrupted in this like voluble prosody called like logoria. And that was actually what Wernicke proposed, which was that we have memories somewhere, and we remember how each word sounds when it's coming in, and we have to remember that when we're both hearing the word and when we're producing the word. And so somewhere those memories get messed up, and which is why we can't understand language or produce language. Which is a really interesting and kind of groundbreaking concept that expanded on this initial all speaking and talking is in the frontal lobes. Because when he looked at these patients, they found it was in the temporal lobe. Which is, and if you're not familiar with brain anatomy, frontal lobe is like right behind your forehead. Temporal lobe is like closer to by your ear. And these are two separately formed lobes. So we're like, wait, we thought speech was in this whole other lobe, but now it's actually in this other lobe. People can still talk, but they can't understand speech.
And for both of these like subtypes of patients, at the time they would have known that they were not like hard of hearing or deaf. Like that was something that obviously with the science, whatever, they could rule that out then. So it's like these people could hear, but then their like sound would get in, but then what would happen next would be different from normal and from Wernicke versus Broca patients. Like aphasia.
What do you mean by different from Wernicke or Broca's
Well, like
patients?
the thing that would get in the way, like the part in the process of hearing, understanding, producing, and then out loud saying speech is different for Wernicke's aphasia versus Broca's aphasia, right? Yeah.
Yeah. So it's what they propose is that they're along the same like timeline or on the same event. So now I kind of want to take a moment for us to like really think about all of the physics that has to happen for like our brains as computers to understand speech, because this is really kind of fascinating to think about. So when I'm like talking to you right now, right? If we were to turn this into like a sonogram, it would just be a bunch of like sound frequencies going up and down, right? So that goes into your ears, which have to interpret the vibrations at a certain point. It has to go through your audio, your audiologic cortex, or perform some kind of auditory analysis on it to separate what pieces of noise are relevant and irrelevant, because you're probably also hearing like your air conditioning or maybe some like ambient noise in the background too. So like all these frequencies are going to your ear, but you have to find a way to isolate the sound that's coming from Preston. And then it has to go to some part of your brain that pulls out which part of those frequencies are associated with words and which of those words have like certain meanings that are related to you. And then you have to like code that meaning, come up with a response, and then assign, okay, my response is going to have certain vibrations associated with it. And then I have to tell that to the motor part of my brain to produce that kind of speech and to come out the other side.
Yeah.
So what we found is that the part of your brain that is interpreting those vibrations, that assigns meaning to each of those, to those words, that's the part in Wernicke's aphasia that is totally messed up. So it's why the brain can still tell the mouth to speak, but the part that's like, there's some part in your data bank in your brain that's like saying, okay, this sound like puh or gur, gruh. That is assigned to us when combined with this other sound, puh or something, is assigned to a certain meaning. And it's like matching them together before it's like shipping them out to turn into a sentence that you speak. That part is totally screwed up in Wernicke's aphasia.
In Wernicke's aphasia, can they understand what the other person is saying?
No, because even when it's coming into you, even when you're hearing it, you still don't know how to
so you don't
extract
know
meaning
ways.
from those.
Yeah. Okay.
Right.
Got it.
There's a total mismatch between meaning or semantics and the vibrations that we're hearing. So they called this the phonologic lexicon, which is basically your dictionary of what does each spoken word sound mean to me, especially in combination. So going in, it's meaningless. Coming out, it's meaningless. Even if they have like some intent of like what they're trying to say. So, and what's interesting is like these patients, they don't try to correct themselves. They make these neologisms, but they're not aware of them. So this kind of like really changed the whole field, so to speak.
And then can you compare that to like Broca's aphasia, just so that the two comparisons right next to each other?
Yeah. So in Broca's aphasia now, the primary problem on that model we just talked about is producing speech only. So before, when Broca was just finding his patients, he thought that was like all of speech. But now it kind of looks like there's an input and output part. So you understand what each word means. So like when you're telling me all of these vibrations, I'm able to interpret them, assign proper meaning to them. But then when I try to export it, now there's a huge disconnect. So my mind can't take meaning and then tell my mouth the words to say. I can't produce the speech anymore. So like, and I want to say like all of these are not like perfect on or off switches. They're like faucets. So there are like patients with Broca's aphasia that they'll only be able to say tan. It was one of the examples that they gave. Or they can say like one word. They'll be like Mike. So they can't produce complex speech, but they can produce some speech. Or the same with like Wernicke's patients. They may say like one sentence over and over again, but then they can't extrapolate or like say more complex things, which is kind of important to think about, that like you have the deficits there, but it's not 100%. They're not completely mute, I guess, so to speak. And this is actually where we can also reflect on how the brain is not totally modular, because they found that there were some Broca's aphasia patients where they only had transient amounts of aphasia. Like they wouldn't be able to speak for a certain amount of time, but then they'd regain their ability to speak. And those patients had lesions in Broca's area, but they were smaller. So when they had smaller lesions, the other parts of the brain were able to kind of reshuffle and compensate, because the brain is plastic ultimately. But the patients had larger deficits, kind of like that whole like left-sided region of the frontal lobe. They wouldn't be able to recover. So we kind of now have two types of aphasia that we're dealing with. And like any model, you start to find that there's exceptions to that. And then you have to go back to the drawing board because that's exactly what we did with Broca's. So one thing that Wernicke hypothesized was that there's a region of your brain that produces speech, and then there's a region of your brain that interprets speech, essentially, assigns meaning to things. And he said, I imagine those two regions are connected. So I wonder if that connection between those two regions was severed somehow, that you could have someone who could interpret speech and produce speech, but would have trouble connecting those two things. So they would have trouble repeating things exactly.
Huh. Yeah.
And that's actually a really profound hypothesis that he formed based on this kind of like working model he made. So we're going to take a quick break, and when we come back, we'll see if he was right about that. So we're back to find out if Wernicke was right. And you probably guessed he was right about that part. So the question being, if there's a part of my brain that interprets and assigns meaning to speech, there's a part of my brain that produces speech. If we sever the connection between them, we'll have some sort of issue continuously repeating speech. And that's exactly what we found, is that there were some patients who could seem to understand speech, but then would make a lot of syntactical or semantic errors when trying to reproduce speech. They were still speaking fluently, but they kind of almost like kept messing up.
Yeah.
They're short circuiting, but then they would recorrect really fast.
You give examples of like syntactical versus semantic?
Yeah. So a great example of this would be if I hold up this glass to you. I'm holding up like a glass of water, and I say, repeat after me. The glass is full of water. You would say the urn is full of water. The vase is full. The glass is full. You know what I mean? So like it's like they weirdly like replaced parts or like single nouns with like synonyms of them.
Okay. Yeah.
And that's actually something that I'll see in like patients in the hospital or something. So I have this like stroke card that I use, and it's just like, if you work in neurology at all, you've probably seen the stroke card, which it's a picture with some kids that are reaching into a cookie jar, and like the chair is about to fall over. And so I've had people call it the cookie urn. They're like, oh, it's cookie urn. I'm like, cookie jar. And they're like, yep, cookie urn. And they like...
Speaking.
I'm like, yeah, like another way that they might kind of make these substitutions would be in like describing water. So another part of this card is like, the sink is overflowing. They might be like, oh, the wet is overflowing. I mean, the water is overflowing. The moist is overflowing, or the moist is too much.
Yeah.
You see how like
close, but not.
Yeah, like they understand what's happening, but they're not like assigning the right words to the ideas that they're trying to convey.
Close, but no cigarette.
Yeah. Excellent. Wow. Yeah. So sometimes they would just have to turn the other head and walk away.
The rest of the episode is just going to be puns.
Yeah. So no, it's exactly like that. So, and that is kind of a severing of what we call the arcuate fasciculus, which connects the temporal lobe and the frontal lobe, so Wernicke's area to Broca's area. Interestingly, though, like if you have someone that can understand but has trouble producing speech, there was actually the inverse of that they saw too. So there were people that didn't really understand speech, but they could repeat pretty easily if you told them to just repeat after me, you know. But then you try to explain things to them, or you ask them to name things, they have trouble like understanding how to name it. And that was the opposite. It was called transcortical mixed aphasia, is what we call it now. And the reason why that those two are kind of interesting is because it suggests that this phonological lexicon we had before actually has like two parts of it. There's one part that is just like the sounds we make, and there's one part that's like the ideas that are assigned to those sounds. And so weirdly enough, there were some patients that when you asked them to repeat a phrase that they understood, they would be able to. So if I say like the cat sat on the tree, they could say that. But then if you ask them to repeat a phrase in like French, where they didn't have a meaning assigned to those words, they were unable to just like repeat the sounds. Because they had deficits in like the phonologic part, the sound part, but not the semantic part.
Got it.
So it's like they would almost use the ideas of the word to piggyback off of the sounds to repeat things. Kind of in total summary now, we have these audiologic inputs. So our ears interpret the vibrations, and then they get divided into sounds. So we have our full vocabulary of all the sounds that we can make and produce. And we have our full vocabulary of ideas and how those are assigned to, and those are in separate kind of regions in this model. And then they combine into our phonogram lexicon, so to speak, all the words that we can produce. And that is where we produce speech.
Complicated. I mean, and I know that this is like merely a skimming of the top of the ice cube, but sorry.
That was another great
one. But complicated, which is why I could never remember it in medical school or now, apparently.
It's not quite rocket surgery, but it's close. and so it's funny. Like, I think that's like a good place for us to kind of stop for now. But actually, if you wanted to keep going, there's like several other layers to this model, including like people that they maybe could understand speech and reproduce speech, but they wouldn't like initiate it on their own. And it comes into this idea that there's like circuits involved in our motivation and not motivation, but ability to like initiate tasks that also affect speech and other things. So we have people that like have spontaneous speech deficits, but are otherwise okay to repeat and understand language and engage in written language. So
it's making me think of like the connection between it and what we usually more think of in child psych as anxiety and like selective mutism, where there like isn't necessarily a hardware problem, like that everything is working correctly, but then the anxiety or emotive part and how that interacts with this system is another part of what you're saying of speech, I would presume. Of how this kind of linked circuit interacts with all the other linked circuits in the brain.
Yeah, and that's where like the modular part of the brain starts to kind of fall apart with that model, because we start to see like, okay, well, like this whole circuit functioning is dependent on another circuit influencing it, and that's the circuit to like decide you even want to do anything in the first place. And the other thing is like, this is a more of a conceptual model, but we aren't able to map all of these like lexicons or dictionaries onto like specific parts of the brain anymore.
Right.
Like we know if we like blow out someone's Broca's area, they can't talk. But outside of that, you know what I mean? It's like really, it's hard to pin down the exact points of someone's like semantic lexicon, so to speak.
It makes me think of how there's also the interaction between, well, I know I just said this offline, but like when we use the term alexithymia, which is like a difficulty or being without word, being able to not put words to emotional experiences. Again, they're not having like a stroke. They have not lost these regions, but just the socialization, practice, and interlooping of these circuits both needing to work well for a function that we kind of call one thing, but is actually very, like all things in the brain, complicated in terms of the interactions. Because like you could imagine if someone has difficulty with word finding in general, that's not going to be like, how do you do therapy with someone who has word finding difficulties in general? I don't know.
Yeah. And it's interesting that like I was just in supervision the other day, and one of the things my mentor was telling me that is, if you can just get someone talking in therapy, they're healing. And he was like, don't like, I think it's like, he's like, it's a great place to start. If they're talking, they're getting better. And sometimes it doesn't even matter what they're talking about. And I'm sitting here like, yeah, well, if the patient has aphasia, they literally cannot be talking.
And you're like, and that's why I started my podcast.
But I think with like a lot of these patients, so I don't personally deal with a lot of acute aphasia patients who have experienced like strokes or other things, but we see a lot of these like very similar aphasias play out in different types of dementias. So in frontal temporal dementia, parts of your frontal lobe can deteriorate that almost start to mimic Broca's aphasia, but it's more of a progressive aphasia that people experience. And so they can get what's called like a logopenic or semantic aphasia. It's very similar to Wernicke's aphasia, but it's like slowly getting worse over time. So what I found with these patients is that even though the parts of them that produce and understand speech are deteriorating, the other parts of their brain that recognize and intuitively respond to human emotion and body language are still very much intact.
Hmm.
So a lot of like the parts of them that recognize that like there's a human and they're expressing a certain thing, they're very responsive to that. So if I like use more like open body language when I'm talking, I express that I'm smiling and I show that I'm interested and welcoming to them, they'll still respond positively to that, even though all these other parts of their like language centers are being taken away from them.
That there is somewhat of the modular part of it where this part of the brain is sort of deteriorating, and the other ways of communicating that on their surface include language are understood from this other part of the communication that we think about a lot in psychiatry. Because that was the other thing I was going to not ask, but wondering about was like, well, you say like semantic meaning of words and the sound meaning, and that like language isn't there. But I think of how in speech then, like when I understand something someone's saying to me, I'm not just like getting the dictionary definition of the word. It like I'm also reading it through the
Mm-hmm.
emotion and, body language, whatever things that are happening too. And
Mm-hmm.
but you're saying in this example, it's like because those things are still like are in a different maybe part, or like the circuit at least is in a different part, it's able to still be known by a patient, even if their semantic and kind of phonetic abilities of speech are diminished.
Yeah, like the meaning of the words are lost in some way, but the intent and the emotion behind them sticks.
Yeah.
And it's really interesting, and I think that you kind of have to remember that when you're talking to patients that have these aphasia disorders. And I think it actually just goes for any any
Yeah.
patient, any interaction. You say in the hospital that people aren't going to remember what you say, but they're going to remember how you said it.
Uh-huh.
Patients with aphasia or language difficulties, it's like that times 1,000. Like they're only going to remember how you say it because they won't have any ability to interpret what you said unless they have a specific, aphasia that with intact comprehension, obviously. But that you can almost like take this as a lesson and say like, okay, like even in my patients that don't have aphasia, like almost like the more important thing I'm going to be doing is going to be expressing with my emotions and my body language and other things rather than focusing on like the exact syntax of my words, which I think is where a lot of people get preoccupied.
Yeah. I mean, I feel like that's part of the limit in some ways embedded in these models is I can't really even like I can understand the like reading and producing speech function like sort of in a vacuum devoid of emotion and human interaction. Like you can think of reading a book, but like it's hard to even understand language like as a concept
Hmm.
and try to totally divorce that from the other contextual parts of it, I guess outside of reading.
Yeah, I guess this is how I'd put it. It's like,
I'm not like I'm not asking. Like I don't. I'm not asking that.
yeah,
I'm more
yeah.
just
I
saying
know you're
like,
not asking. I'm also reflecting on it. I think I would say like language is one of the many ways we communicate,
hmm,
but is not like the only way. So it's like even if someone's aphasic, unable to articulate, understand, or like reproduce written or spoken language, that does not mean that they're beyond being communicated with.
yeah,
And we have many other tools. So that's also like the part of like the modular brain that doesn't hold up, which is like, oh, this part is responsible for communication. Well, like communication is a really broad term. It's the ability to translate one idea from one human to another. And words are one way to do that. And words
yeah,
have a really complex system, but there are many other ways that you can translate ideas.
yeah. What do you make of like we talk about the musicality of people's speech or like the rhythm of it?
Hmm.
How does that fit in your mind? I'm sorry, I'm asking Preston to go off script right now, but like
Oh, sure.
I'm like thinking of this, of like thinking of patients with like pretty severe depression, or like who are experiencing the flattening of like prodromal, like before their first break for like schizophrenia.
Yeah, like the way their prosody starts to flatten out and they
And
become more
well,
robotic.
and we say that's indicative of like emotion, but at its core, it's still a function of an ability to produce a type of speech.
hmm
So is that flattening indicated in this circuit? I'm asking you
yeah, so
off the
I don't
dome.
know
I'm sorry.
anything about how these circuits affect prosody.
Yeah.
But this I guess is a whole other like topic for me. I do find prosody very interesting. So like if you follow someone's intonation over the course of like a sentence, it obviously implies certain things about what you're saying, even if you're saying the same thing each time. So like if you, I think we most of us know this, but like if you raise your intonation or you raise the frequency of your voice towards the end of a sentence, you're implying a what?
Question.
Yeah, question, right? So if I'm like this is a glass of water because I'm holding a glass of water, I feel like this is a glass of water.
It's an urn.
this is this is a wet of urn. But then if I drop my prosody or intonation at the end, it kind of conveys more authority. This is a glass of water. One person who does that really well is Michael Barbara from The Daily. I love listening to him, and I always think about how he applies his prosody. He's like, "This is Michael Barbara, and we're with The Daily." He doesn't say, "This is Michael Barbara with The Daily." Interestingly, if you raise your frequency and then drop it, that's like a way to sell punchlines or jokes.
Really?
Yeah, this is a
Try it.
glass of water.
I feel like I like never.
What are you doing with your headphones? That
I
wasn't very
feel like
good.
I believe you. I believe you in theory. So do you use this? Do you think of this when you're like talking in the podcast?
I mean, I don't try to like sell it when I'm doing different jokes, but sometimes it works, if you know what I mean. Like that'd be an example of me like trying to apply it. I think it's just a way to set up like into the anatomy of a joke, which is like a lingering question or uncertainty followed by a punchline. So like the joke or the punchline should be able to live on its own, but the prosody is a way to reinforce that. If that
I'm
makes
thinking
sense.
of the Norm Macdonald, like the moth joke. I mean, he did stay up here, and then he goes down at the end. It's like your light was on, like, and then
I don't
it
know
doesn't fall.
Norm Macdonald's like the best example of that.
I think go watch
Yeah.
him on Conan. It is
Okay, with the moth joke. Yeah,
You're right.
he was
There's
just
waves,
such a
but
maverick of comedy that I'm like wondering if he's like following the like the tried and true methods. But I'm sure he has a lot of classics like that.
I love Norm Macdonald. May he rest in peace.
Why'd you go into the restaurant anyways? Well, the light was on.
No, it was. That's what I'm saying. That's what I literally just
Okay, gotcha.
said. I'm gonna kill you. Okay. I interrupted your train of thought entirely with my questions. So where were we going next?
Oh, as we kind of like wrap up and summarize, we have been like thinking about like the different ways that people interpret and produce speech. I was thinking about like going through a game, but I don't know if this is like the best one to do a game with.
Are you gonna quiz me?
No, I'm not. I'm not.
Okay,
Not
I was like, it's not gonna go.
So I guess I don't have much else to say. Ironically, in this aphasia episode, I think that like
Why do you think about this as a psychiatrist?
because I think personally I'm just always very fascinated by the like interplay or the interlocking of like the brain and the mind. And so I'm trying to remember that like everything that controls some kind of like expressive or verbalizing process that someone has the potential to be like disrupted in a mechanical way. And the same applies when like you have emotional dysregulation after a stroke or something like that. So I think that like when I'm trying to anchor on all these ways or understand all these ways that our lived experience can be disrupted as our brains change, it can be helpful to then develop empathy for people that are in these situations. So it's one thing to be like, oh, this person can't talk, so I'm going to like address their caregiver. I know I'm going to like fundamentally believe that all of like my words are going to fall on deaf ears, or that's kind of like pointless to put in effort. But you could say if you start to understand more how language is processed and how people are attempting to interpret the words you're saying and also produce speech themselves, it lets you find ways that you can meet with them on their level and see them as a fellow human, I guess. So weirdly enough, like the more I learn about how the brain works, the better I get at coming closer or sitting with someone in their personhood, I guess, is what I would say. So I know that Margaret loves to hate on neuro, but
I don't love to hate on neuro. I just didn't
just
choose
hate
to be a neurologist. You were torn between psych and neuro.
Yeah, very true.
I think most psychiatry. I think it's good that you know this stuff. And I think neuropsych is really important as we, in general, but like as psychiatry hopefully continues to advance. So that's why it's good for me to have you teach me these things on the podcast and our audience.
Yeah, and I hope that you don't come across a lot of this in your child and psych endeavors.
Well, when you were saying it, it made me think of how you understand. Like I was thinking about, I had like an orientation to the pediatric emergency room and the like acute psych unit. And we were talking about everyone's roles. And then they were talking about child life and then OT. And a lot of the things that OT does for psych and peds especially is figuring out different ways of communicating, more so with like kids with different developmental considerations. But it made me think of like how OT would be useful in some of these patients, right? And are useful, I'm sure. But like if there was the same level of OT availability at all adult like neuropsych units, maybe the way we interact with those patients, like you're saying, would be different. And if we had someone whose specialty is understanding different ways of navigating the day-to-day life environment and clinical environment, like how would they weigh in on, which we need to have an OT on the show. So, but it just made me think of that, of like thinking about just like differently abled. How do we make people who have different abilities and different disabilities able to get care in the best way possible?
It all comes from the village, I guess. And I think the more we can understand about like the ways we can get every individual group involved, it's like it's like how you improve someone's experience.
Yeah. All our different lenses.
Yeah. Well, that being said, I think this is a shorter episode, but it was fun to go through all the aphasias with you.
I learned something.
And you had plenty to say, yeah. And to you listeners, if you like us kind of talking about these more like niche or like insulated topics, we're happy to keep doing them. If you're a med student who is listening, I know Broca's aphasia, Wernicke's aphasia, the arcuate fasciculus, conduction aphasia, transcortical mixed aphasia, those are all fair game as you're studying. So
they
like
are in
maybe
our boards too.
Yeah, maybe you'll get some benefit from it. Like even
like selfishly, I was like, yeah, I need to study this, Preston.
So you'll get some benefit from all that at least. If you want to come chat with us, you can always reach out to us at Human Content Pods. We're on Instagram and TikTok. If you want to watch full videos of this, it's on my YouTube at It's Presro. You can always see Margaret at Bad Art Every Day on Instagram and TikTok. Shout out to everyone who's been leaving nice comments. I know people have been reaching out with lots of questions, especially on YouTube. I know we got a lot of questions about kind of forensic psychiatry after our last episode that was on the psychiatric detainment process. So we hear you and we've seen a lot of those. I think we're going to start looking at getting a forensic psychiatrist.
And our next episode is a forensic psychiatrist.
Yeah.
So we have our first forensic psychiatrist coming on, but we will have others, I'm sure, because there's so much to legal that I feel like is like the complex and controversial parts of psychiatry.
Yeah, exactly. Thanks again for listening. We're your hosts, Preston Roche and Margaret Duncan. Our executive producers are me, Preston Roche, Margaret Duncan. Duncan. See, now my ability to produce speech is getting impaired. Will Flannery, Kristen Flannery, Aaron Corney, Rob Goldman, and Shanti Brooke. Our editor and engineer is Jason Portizo. Our music is by Omer Benz-V. To learn more about our program disclaimer and ethics policy, submission verification and licensing terms, and our HIPAA release terms, go to howtobepatientpod.com or reach out to us at howtobepatient@human-content with any questions or concerns. How to Be Patient is a human content production. Thank you for watching. If you want to see more of us, or if you want to see, this is Lilac, she's my cat. She's going to be waving her hand at one of the floating boxes, which will lead to more episodes. Lilac, point to the other episodes. Lilac doesn't know what the internet is, but I swear they're there. They probably exist for real. But in the meantime, I'm just going to pet Lilac, and then I'm going to go dance in the background.